So, good morning. I want to welcome you to our resident lecture. This morning, Francesca Dacanal, who's a first-year resident at our department, will talk about lower gastrointestinal bleeding. We also want to thank Professor Gubler for helping us on preparing this presentation. Unfortunately, he cannot join us, but Dr. T from the gastroenterology and Dr. Pube from the radiology could join us. Thank you very much for coming. What you would like to underline is the importance of the multidisciplinary approach when treating this patient. So enjoy.
So thank you very much for your introduction, and thank you very much to our guests for coming. So today I'm going to speak about lower GI bleeding. If we receive a patient with a GI bleeding, we have to ask some questions. Is it an active bleeding? Where is the bleeding? How is the workup, and which is the appropriate treatment for the bleeding? Gastrointestinal bleeding refers to any bleeding that starts in the gastrointestinal tract. And upper GI bleeding is a blood loss originating proximal to the ligament of Treitz. So a bleeding coming from esophagus, stomach, or duodenum. A middle GI bleeding is when the source of bleeding is located between the ligament of Treitz and the ileocecal valve, so a small bowel bleeding. And a lower GI bleeding is a bleeding that occurs distal to the ligament of Treitz. So if we have a patient with a GI bleeding, it's important to remember that what comes up may go down. In fact, in 70 to 80% of the cases, it will be an upper GI bleeding. The gold standard to identify an upper GI bleeding is an upper endoscopy. In the past, the exclusion of upper GI bleeding was even done by nasogastric tube with blood sampling from the stomach, although due to the poor negative predictive value documented in literature is no longer recommended. So an upper GI bleeding is much more common than a lower GI bleeding, even if over the past decade, as shown in this population-based study of Lanas et al., there has been a progressive change in the overall picture of gastrointestinal events, with a clear decreasing trend in upper GI bleeding from 80 to 40 per 100,000 patients, probably even due to the incrementation of PPI use, and a significant increase in lower GI bleeding events. Contemporary data suggests that patients with lower GI bleeding tend to have a longer length of hospital stay and may be at higher risk of death or rebleeding. A lower GI bleeding has an incidence of 33 per 100,000 patients, with an associated mortality rate of 2 to 4%. The incidence is higher in older patients and patients taking multiple medications, as well as in male patients. A lower GI bleeding can present in 4 different ways. Melena, which is black tear and full-smelling stool containing partially digested blood. Hematochezia, which is blood mixed with stool. It can just present as frank blood with the acronym BRPPR, which stands for bred red blood per rectum. Or last, as occult bleeding refers to a bleeding without the presence of symptoms, because the blood loss is either so small or so gradual that the patient doesn't realize it. Approximately 80 to 85% of lower GI bleeds originate distal to the ileocecal valve. In around 10% of the cases of lower GI bleeding is still an upper GI bleeding. And in around 42% of the cases, the bleeding is coming from multiple sites. So only a few bleeding originating from the small intestine. So jejunum and the ileum are the overall least common location for a lower GI bleeding. That may also be confounded because the diagnosis in that place is difficult. So which is the first approach to a patient with a lower GI bleeding?
I would say, first of all, maybe take a history.
Yeah, right. So when comes a patient with a lower GI bleeding, first of all, we have to assess the severity of the bleeding. So get the anamnesis and the history of the patient. So color of blood after painful defecation, abdominal pain, as well as comorbidities. And really important is even to ask for medication that can promote the bleeding. Then the physical examination, so take the vitals, and then if we can assess the severity of the bleeding. So if you have to approach an inpatient patient with acute lower GI bleeding, after the initial resuscitation, a CT angiogram provides the fastest and less invasive means to localize the site of blood loss, together with an upper endoscopy to exclude an upper GI bleeding. CTA has reported high sensitivity and a high specificity. The upper GI endoscopy has always to be performed unless the CT angiogram has identified the source of the bleeding in the lower GI tract. And then we can proceed for lower GI endoscopy or embolization to treat the bleeding. Unstable active lower GI bleeding represents about 1 to 2% of all hospital emergencies. In 15% of the cases is a massive bleeding, which involves most of all patients older than 65 years. And it's generally correlated with hematochezia or frank blood per rectum. In case of stable bleeding with a major bleed, a colonoscopy is recommended to be the preferred initial investigation because of its potential for diagnosis and application of different therapeutic modalities. An upper endoscopy should be performed as well if a clear bleeding site hasn't been identified in the colonoscopy. Colonoscopy appears to be safe with no evidence of increased complication compared with other interventions. And in presence of a normal endoscopy, we have to go for other investigations such as capsule or MRI enterography. The cause of lower GI bleeding are very heterogeneous, and as already mentioned, mainly concern the colon. So first of all, I would like to mention the diverticular bleeding, because it represents about 30% of the cases of lower GI bleeding. Quite common, about 19% of the cases, is the bleeding originating from vascular causes, either angiodysplasia or ischemic colitis, coming from a shock or an embolus or arteriosclerosis of the mesenteric vessels. In about 9% of the cases, bleeding comes because of inflammatory bowel disease. A bleeding can come even because of a neoplastic disease or because of benign anorectal disease. Uncommon, but still important to mention, are the iatrogenic cause of lower gastrointestinal bleeding, such as post-polypectomy or radiation colitis or proctitis after, for example, prostata cancer. The most common cause of an acute massive lower GI bleeding, as already mentioned, are diverticulosis and angiodysplasia. The diverticulosis hemorrhage is the most common reason. In about 60% of the cases, we have a severe bleeding. And it is correlated with substantial cost of hospitalization. The sigmoid colon is the most common site. And in 50 to 80% of the cases, it stops spontaneously with the risk of rebleeding up to 10% within 5 years. Patients with diverticular bleeding are candidates for endoscopic treatment. Therapy options at coloscopy include injection therapy with adrenaline, endoscopic treatment, clipping, or thermal therapies. The clipping is usually preferred because it's easier to do and less dangerous. If with the colonoscopy the bleeding cannot be stopped, a transcatheteral arterial embolization should be performed. And surgery is indicated just for patients with ongoing bleeding after failure for the other intervention, or for patients with recurrent severe diverticular bleeding. The angiodysplasia is the second most common cause of severe lower GI bleeding. It is an arteriovenous malformation with acquired degenerative lesion secondary to progressive dilatation of normal blood vessel within the submucosa of the intestine. Cecum is the most common sign, The presentation can be very heterogeneous, from occult bleeding to life-threatening bleeding, and usually needs an early intervention. The treatment of choice in this case is considered the endoscopy with argon plasma coagulation. And they are the most common differential diagnosis of moderate to occult bleeding. So first of all, a moderate bleeding is common symptoms in patients with inflammatory bowel disease. It may present a bloody diarrhea, usually mixed with mucus. The probability of bleeding increases with the duration of Crohn's disease from 1% after 1 year of Crohn's disease to 10% after 20 years. Acute lower GI bleeding in ulcerative colitis is often the setting of severe disease refractory to medical therapy. And in overview of emergencies in inflammatory bowel disease patients, up to 10% of all the urgent colectomy were performed because of an acute bleeding in the ulcerative colitis. Ischemic colitis occurs when the blood flow to a part of the colon is temporarily reduced. The diminished blood flow doesn't provide enough oxygen for the cell, which can result in tissue damage to the disaffected area of the intestine. It may be present with a bloody diarrhea, usually associated with abdominal pain. Important is in this case that the feature of peritonitis indicate a surgical management. Another different diagnosis for moderate or occult lower GI bleeding are, of course, the neoplastic disease. They usually present with a painless bleeding, which is usually intermittent and slow in nature. The benign anorectal disease are a very common reason as well. They are, for example, hemorrhoids, anal fissure, and anal ulcers. In that case, a significant bleeding is uncommon. We should not go for a benign anorectal disease until other causes have been excluded. And usually, a bleeding coming from that cause involves patients with coagulopathies or that are receiving anticoagulants. The prevalence of hemorrhoids are about 4.4% in the general population worldwide, and that's why hemorrhoids are one of the most common cases of lower GI bleeding. Usually low volume, fresh bleed seen in toilet as splash in the pen or on toilet papers. They are generally caused by chronic constipation. Anal fissure are usually longitudinal splint in the skin of the anal channel, presents with painful defecation, with streak or fresh blood over the stool. To better classify a stable lower GI bleeding in order to understand the need of hospitalization, a risk assessment tool called Auckland score can be used. The Auckland score classifies stable bleeds as major and minor. It comprises 7 variables that are routinely measured during initial clinical assessment, such as age, gender, previous hospital admission with lower GI bleeding, digital rectal examination findings, heart rate, systolic blood pressure, and hemoglobin value. In case of Auckland score major than 8, the patient will benefit from an hospital admission. And in case, if the score at presentation is lower than 8, we can proceed for a safe discharge with outpatient follow-up. So the treatment of lower GI bleeding is multidisciplinary. The options to arrest the bleeding include endoscopy therapy, transcatheteral mesenteric embolization, and surgery. However, many lower GI bleeding will stop spontaneously. The colonoscopy should be the first diagnostic modality for hemodynamically stable patients with acute lower GI bleeding because of the therapeutic option it offers. The colonoscopy should only be performed following adequate bowel preparation using large volume of PEG solution, with eventually even the use of a nasogastric tube for the administration in case of nausea. Colonoscopy should be performed during the hospital stay because there is no evidence of a better result after a colonoscopy performed within the first 24 hours. That concept has been confirmed in the study of Nikura et al. From 2020. That's a randomized control study between 15 hospitals in Japan of 159 patients, which were assigned to two different groups. One that underwent early colonoscopy within 24 hours from the initial visit to the hospital, and the other one that underwent elective colonoscopy. The primary outcome was identification of stigmata of recent hemorrhage, and the secondary outcomes were rebleeding, hospitalization, and 30 days mortality rate. It has been shown that colonoscopy within 24 hours after hospital admission did not increase the identification of the hemorrhage or reduce bleeding or mortality, compared with colonoscopy performed within 96 hours in patients with lower GI bleeding. The transcatheteral embolization should be reserved for the treatment of acute, potentially life-threatening lower gastrointestinal bleeding, either in hemodynamically unstable patient with active bleeding or in patient with ongoing bleeding, not aimable or not effectively treated by endoscopy interventions. The embolization should be performed within 60 minutes for the hemodynamically unstable patient, since the time has proved a significant factor in the prognosis of that kind of patient. The embolization doesn't need a bowel preparation, and it has a high success rate of stop the bleeding if a bleeding is seen, because for the embolization it's not always possible that bleeding has been seen. It needs to have a quantity of bleeding, active bleeding, at the moment of the CT. It has even a major complication, such as bowel ischemia in 7 to 24% of the cases. It has a short-term rebleeding rate from 10 to 50% and a long-term rebleeding rate of 25% in 2 years. There are no direct head-to-head trials or retrospective study of embolization versus endoscopic treatment. Therefore, the choice of treatment has always to be determined by individual patient factors, local expertise, and resource availability. Laparotomy for acute lower GI bleeding is undertaken when the endoscopic or radiological intervention measure had failed. Although there are some uncommon instances, such as an aortenteric fistula, when proceeding directly to surgery may be justified. Proceeding to laparotomy without localization of the source of bleeding can be particularly challenging, and given the well-established risk profile of emergency surgery should be avoided. Surgery should only be taken if the lower gastrointestinal bleed is due to pathology that are not amenable to endoscopic or radiological treatment. Emergency subtotal colectomy is an effective and definitive method of treating unlocalized massive lower GI bleeding, but it's associated with a high mortality and morbidity. Anticoagulant and antiplatelet use is reported in up to 30% of patients with acute lower GI bleeding, and temporary withholding of the oral anticoagulants and antiplatelets at the presentation in patients with a major bleeding is suggested. For a minor self-limited bleeding with an Auckland score less than 8, the anticoagulation therapy doesn't need to be suspended. So, the take-home message of my presentation are, first of all, assess the severity of the patient and proceed to an angiocytis if the patient is unstable, and to a colonoscopy for stable patient. It can be useful to calculate the risk assessment using the Auckland score to understand if a patient needs to be hospitalized or if we can proceed with going treatment. The surgery has to be performed in lower GI bleeding just after the localization of the bleeding, and it always has to be connected with the cause of the bleeding. Don't forget that it could be an upper GI bleeding, which is much more common than a lower GI bleeding. And don't forget to ask if the patient are taking an anticoagulation medicine. Thank you for your attention.
One question is, this is frequent, that deal with any hospital, any surgeon, gastroenterologist, we have to deal with this condition, people coming. Do we have a care map here? Do we have in a big hospital a way with these guidelines here? We have done an interdisciplinary care map, how to handle this patient when they arrive in the emergency until we do whatever procedure that was very well presented by Francesca today.
To my knowledge, there's no care map, but please correct me.
I agree. There's not a protocol or a written procedure how patients are being evaluated in this hospital multidisciplinary. There's of course the guideline, the European guideline, which is most often being used, but there's not a standard procedure.
A number of these cases are very frustrating, right? Because they are bleeding or they are coming several times. We don't know where it is, and then we have to go to all the list. Sometimes it's angiodysplasia or something. What's the role of capsule endoscopy here? Do we do it only electively? Is there any role of this capsule endoscopy in a relatively acute situation?
Good question. Of course, often it's a cumbersome situation with a GI bleed. Most often, if hemodynamically unstable, we start with an upper GI investigation with the gastroscopy and then a colonoscopy. And if there's no lesion identified to be the cause of the bleeding, a video capsule endoscopy can be considered, but is mainly a elective procedure, which can be planned and sometimes even be done in an outpatient clinic situation.
Thank you, Francesca. Very thorough presentation. I think you covered all the important aspects very well. Thank you very much. I just have 2 points to touch on, and one is the proctologic examination. I think that's a very important part in these patients, and oftentimes it goes unnoticed. I can remember more than one patient that we were called from the cardiovascular intensive care unit where they've had a patient who has to be on anticoagulants and he's bleeding and they cannot find the source and he's had multiple interventions and you go examine the patients and literally there's a bleeding hemorrhoid and 3 minutes and a Vicryl 3.0 suture ligation later the bleeding has stopped. So I think whenever you're called to see a patient with a bleeding of unknown origin or a lower GI bleeding that cannot be stopped is always do a thorough examination yourself, have a finger in the rectum, take a look and exclude a bleeding hemorrhoid or another bleeding proctologic source. The second thing I'd like to touch on is the value of interventional radiology. And you've shown this one slide and maybe we can bring that up once again. Now we have an excellent interventional radiology service, and I would like to hear Dr. Gilbert Puip's opinion on this. But when just looking at this list, looking at the contra list, you find that there is 25% of bowel ischemia, there is 50% of rebleeding, either short-term or long-term. It appears to me that this is quite an extensive list of complications. So when should we go to interventional radiology? When should we call you? And when should we go back to endoscopy or straight to surgery?
Yeah, usually we get involved when endoscopy fails. So they go in with the colonoscope and they just see blood. And the patient is getting more and more unstable, and then usually the CT is already done when we were called. And what we see, so from the side of the complications, I think 25% of bowel ischemia, this is pretty high. So we had a few cases here, but compared to the amount of cases we do, I think we are less than 7. So it occurs. for sure, but this is a little bit depending on the technique of embolization, which is not standardized. We usually use coils, so you preserve the collaterals. So usually this is not so much a problem. The rebleeding rate is a problem. If you cannot go and super selectively embolize, this is something we see. And one big problem is the interval bleeding. So we usually see the patient, so he was bleeding massively, they do the CT scan, and it takes time until the patient is intubated, get up to the angio, etc. And when he comes to the angio, is stable, completely stable. And then it's also questionable to do the angio. And meanwhile, I'm pretty good in determining whether I can see a bleeding or not, just looking at the patient. When he's completely stable, then usually we don't see anything. And this is the cause because 85% stop spontaneously. But we have the issue that a lot of patients are on antiplatelet drugs, anticoagulation, and all this stuff.
I'm just always a little bit scared when I hear embolization of terminal colonic vessels. Now, how selective is super selective on the colon?
Very super selective.
Very super selective, like extremely super selective.
You get to the vasa recta. You can go to the level of the vasa recta, but it depends a little bit. Sometimes you close one vasa recta and you think job's done. You retrieve the catheter a little bit and then it starts bleeding from 2 other collaterals. And then you always have to think about what to do.
Now, to me, there's just not one surgical patient where we can say, well, either we do interventional radiology or we go to surgery. Sometimes surgery can be extremely complicated and can be very risky and dangerous. But in some other patients, surgery may be very simple. Like maybe Professor Lehmann, if you have a tumor in the small bowel that's intermittently bleeding, would you rather go for interventional radiology, or should we quickly take out that loop of small bowel?
I think the answer is very clear to that. If you have a bleeding source on any kind of imaging or endoscopy, surgery is always an option to stop that. I think the big problem in GI bleeding is the unidentified source. I have another question in this context. You mentioned lower endoscopy for unstable patients. Ole, can you comment on the role of a colonoscopy in an unprepared patient? Should we do that?
Preferably not. I think the algorithm was nicely shown. I think if you have an unstable patient, first there has to be tried to stabilize the patient. If not possible, that's the indication for a CT angio. And colonoscopy should preferably only be done after effective bowel preparation.
Yeah, when you have a bleeding and then you go and we don't find the bleeding, you do the angiogram, no source. Do you give sometimes papaverine? It's been some stress tests with some very good results. Some people are scared, of course, to give papaverine in the setting. But I think the worst news is not to find the bleeding. So what's the strategy here?
What you can do is, before doing this vasodilatation procedures, is you can take CO2. CO2 angio is a little bit more sensitive, even for smaller bleedings. But it needs a good cooperation with the patient. Usually they are not intubated, they're spontaneously breathing, they get medication and everything, and they don't listen to any command you give. So this makes it very difficult. I personally do not like to make these provocation maneuvers, especially in patients when you're not sure that you get there quickly with your cat. That is really jeopardizing the patient's condition. When you are sure that you get there, and you're pretty sure that the bleeding source is there from the CT, and maybe you can do that. But you must be there with the cat pretty quickly.
Okay, so Francesca, thank you very much. Daniela, thank you very much. We learned a lot. Thank you.